Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues, exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this episode, we're talking with an expert on the subject of motor neuron disease. Before we start, for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section of your CPD. Well, motor neuron disease, MND, refers to a group of relatively rare neurodegenerative diseases in which motor nerves in the spine and brain lose function over time. It affects about 2,000 Australians, which equates to about 1 in 11,000. There are 2 new diagnoses per day, with a 1 in 300 lifetime risk. About 60% of cases are male and 40% are female. The highest prevalence rate is reported in males aged between 75 and 84 years. So in 10% of cases, there's a hereditary basis, although the genetic fault is only determined about 60% of the time. Well, there are several forms of MND, which are classified according to their hereditary basis and which neurons are affected. These include amyotrophic lateral sclerosis, or ALS. And this is the most common type of MND. It affects both the upper and lower motor neurons, the neurons in the brain and the spinal cord, which then affects the muscles of the arms, legs, mouth and respiratory system. On average, people with ALS live for 3 to 5 years after receiving the diagnosis, but with supportive care, some people live for 10 years or longer. And the renowned English physicist Stephen Hawking lived with ALS for many decades until his death in March 2018. He had the disease for 55 years, which is the longest recorded existence with this condition. The American baseball player Lou Gehrig also had ALS, and this resulted in people calling it Lou Gehrig's disease. And Neil Danaher's very public diagnosis in Australia in 2013 has significantly raised awareness for this diagnosis, and 10 to 15% of cases are associated with the development of frontotemporal dementia. Next, there's primary lateral sclerosis, and this rare form of MND affects the neurons in the brain and advances more slowly than ALS. It's not fatal, but may affect the quality of life. And juvenile form is also described. Progressive bulbar palsy, PBP, involves the brainstem. Patients with ALS often have PBP also. PBP causes frequent choking spells and difficulty speaking, eating and swallowing. In progressive muscular atrophy, which is rare, the effect is on the lower motor neurons in the spinal cord. This causes slow but progressive muscle wasting, especially in the arms, legs and mouth. With respect to spinal muscular atrophy, SMA, this inherited MND develops in children. There are 3 types, all caused by a genetic change known as SMA1. It tends to affect the trunks, legs and arms. The long-term outlook depends on the type. Kennedy's disease is also inherited. It only affects males, and females may be unaware carriers, and often presents with shaking hands, muscle cramps and twitches, with weakness in the face, arms and legs. Affected males may have trouble swallowing and speaking and develop gynecomastia and azoospermia. Now to causes, well, experts believe that around 10% of MND are hereditary, with other 90% develop randomly. The exact causes are unclear, but the National Institute of Neurological Diseases and Stroke reports that genetic, toxic, viral and other environmental factors may play a role. Now, one area of interest in the inherited MND ALS patients has focused on the build-up of clumps of misfolded RNA binding proteins in the neurons of ALS and frontotemporal dementia patients, referred to as FUS. This protein leads to premature death of neurons. FUS proteins can change back and forth from small liquid droplets, resembling oil droplets in water, to small gels inside the nerve cells. As the FUS proteins condense from droplets to gel, it captures RNA and transfers it to remote parts of the neuron that are involved in making synapses with other neurons. Here the protein melts and releases the RNA. So the RNA is then often used to create new proteins in the synapses, which are essential for keeping the synapses working properly, especially during memory formation and learning. And in frontotemporal dementia and ALS, the proteins become permanently stuck as abnormal dense gels, trapping the RNA and making it unavailable for use. In motor neuron disease, this was caused by mutations in the FUS protein itself, which meant that it no longer was able to change its form. So this research provides new ideas and tools to find ways perhaps to prevent or reverse the abnormal gels of FUS in that very particular genetic form of ALS. It lends hope to other research. Now, it can be difficult to diagnose MND in the early stages, as it may resemble other conditions such as multiple sclerosis or even a small cerebrovascular accident. However, muscle fasciculation weakness and slurred speech should trigger suspicion. The different types of MND cause similar symptoms and have early, middle and advanced stages of progression, which occur at different speeds and vary in severity. And patients reporting weakness of arms and legs, weak grip, clumsiness and stumbling, dysphagia and inappropriate emotional responses may be manifesting early signs of MND. This may lead to muscle shrinkage, difficulty moving, involuntary yawning, breathing difficulty and drooling. A 2017 study suggested that up to half the patients with ALS experience brain involvement, including memory and language problems, and reports that around 12 to 15% of people with ALS develop a dementia referred to as the frontotemporal dementia mentioned formerly. In advanced stages, basic functions including breathing and movement may become life-threatening and are the most common cause of death. Well, in the diagnosis of MND, it's noteworthy that there are no identifiable biomarkers, and whilst brain and spinal cord imaging by MRI or CT is useful in excluding other conditions, there are no specific identifiable features of MND. Drugs appear to be effective at slowing the progression of some types of MND. For example, riluzole reduces the presynaptic release of glutamate and increases short-term survival in ALS. Edaravone is a free radical scavenger and slows disease progression in mild disease. Botox injections can block the signals from the brain to the stiff muscles for about 3 months at a time, and baclofen may be used for muscle relaxer. While physical therapy can assist in alleviating cramps and stiffness, and anti-inflammatories may be helpful with mild to moderate pain, muscle cramping and spasms. Of course, physiotherapy and speech pathology are integral parts of the management team, as it is important to look after their mental health. Well, the outlook for people with MND varies widely depending on the type of the disease. People with SMA, for example, can expect to have a typical lifespan, whilst other types of MND are associated with reduced life expectancy, as mentioned previously, and survival may be measured in just years alone. Emerging therapies, including the use of stem cells, are awaited with hope. Well, in this episode, we have the privilege of exploring this subject further with Associate Professor Ernie Butler, a consultant neurologist and founding member of Frankston Neurology Group. He has major clinical expertise in the management of multiple sclerosis, myasthenia gravis, and Parkinson's disease. He has appointments as the head of neurology at Peninsula Health, as a senior neurologist at Monash Health, and as the head of the Monash MS Clinic. We've had the honour of working with Ernie previously in episode 88 on multiple sclerosis and episode 89 on myasthenia gravis and Guillain-Barré syndrome. So please welcome him back to the podcast. Dr. Ernie Butler, welcome back again to Everyday Medicine. Thank you for being my favourite neurologist, favourite interviewee. I think you've got the record now with a number of interviews, so thank you very much for being so patient. We're going to talk about motor neuron disease, and this is another neurodegenerative disorder, and it said that about 2,000 Australians have this condition, and GPs are likely to see one or two of them in their clinical practice over many years. I think the condition has been brought to the fore in Australia by Neil Danaher, his movement through the AFL, and I'd like to try and improve my understanding of it, maybe share your experience. Can you tell us a little bit about motor neuron disease? What is it exactly and how we classify it? I've been confused about the classifications. Can you take us through this? And then we'll go through approaches to treatment and so forth.
So motor neuron disease, as the name implies, is a disease that targets motor neurons, and it either targets upper motor neurons that are in the motor cortex, or lower motor neurons that are in the brainstem or in the spinal cord, in the anterior horn of the spinal cord. Right. And it leads to cell death of those motor neurons. And as a result, it causes weakness. And eventually it spreads to it starts usually in one body area and spreads to other body areas. And as I think we're all aware, it's a horrendous condition. It's very serious and it's life-limiting. Now, in terms of the classification, there are various types of motor neuron disease which are associated with different prognoses. The commonest form of motor neuron disease is what's called ALS, or amyotrophic lateral sclerosis, where the lifespan is usually 3 to 5 years after diagnosis. And that's a mixture of upper motor neuron features and lower motor neuron features in the patient. And we're all aware of what we should see with upper and lower motor neuron, but I'll just briefly say yes. Weakness is common to both upper and lower motor neuron patterns of weakness. In a lower motor neuron pattern of weakness, we expect to see muscle wasting, muscle fasciculations, sometimes muscle cramps. And in some with an upper motor neuron pattern, we expect to see they have hyperreflexia, they have increased muscle tone, and they have other features such as hyperreflexia. Sorry, did I mention that already?
No.
Hyperreflexia and extensor plantars.
Yes.
So that's ALS. That's the most common type.
And that's what Lou Gehrig had as well, but the Americans refer to it as Lou Gehrig's disease after the baseball.
Right, that's right. The famous baseballer who was around at the time of Babe Ruth. He was very young, developed MND, and Americans often call it Lou Gehrig's disease.
Yes.
Although the generally accepted correct term is motor neuron disease, of which ALS is the most common type.
Right.
Now, the other types we see, there's a type called progressive lateral sclerosis, where there's sclerosis of the corticospinal pathway,
yes.
usually seen in the spinal cord pathologically, and that's a pure upper motor neuron variant of MND. Now, it's important not to confuse this with hereditary spastic paraplegia, which can look similar, but HSP should be symmetrical. Primary lateral sclerosis, in my experience, is usually an asymmetrical onset condition, but it eventually spreads from one limb to other limbs, or from one side of the body to the other side. And that's usually associated with probably the best type of prognosis with MND.
Right.
There's a type called progressive muscular atrophy, which is a pure lower motor neuron variant of MND. It often starts in the hand, for instance, and then spreads in the same arm, often goes to the other side or into the leg, and eventually spreads to all four limbs. And the longer someone has that, the more likely they are to develop upper motor neuron features eventually.
Right.
Also, that seems to have a better prognosis than ALS. There are other variants of MND. You can have a pure bulbar onset to motor neuron disease. Probably at least 10% of patients with MND will have bulbar onset of symptoms where they have troubles with speech and swallowing. And there may be a mixture of upper or lower motor neuron features, or just either, with a pure bulbar onset to motor neuron disease. That's usually associated with a worse prognosis, and it may or may not spread to involve the limbs, but eventually it spreads to involve respiratory muscles, just like ALS does. And there are other variants of MND, such as the flail arm variant, where a patient will lose proximal muscle power in both arms, still have some finger movements, but really they have, as the name implies, flail arms. They have no purposeful movement in their upper limbs as a result. And occasionally you can get a flail leg variant as well. And those variants are also associated with a better prognosis. When I diagnose someone with MND, I say, the average, we just talk about averages, prognosis, because everyone wants to know about prognosis, is 2 to 3 years for a lot of patients.
It's not long, is it? Not long at all.
But I always give them hope by saying 25% of patients are still alive at 5 years.
Yeah.
About 10% of patients are still alive at 10 years.
Yeah.
The diagnosis, sometimes it's not easy to tell exactly what their prognosis is going to be unless they have one of these variants associated with, more severe problems.
So if you have a bulbar, the bulbar involvement, does that usually progress reasonably quickly in terms of swallowing? I might see that in gastroenterology. Someone comes in with swallowing. I can think of one patient that I was familiar with that had this condition. I didn't actually pick it, so that's bad on me. But generally, would that progress reasonably quickly, or can it be reasonably subtle for a 6-month, 8-month period?
Look, it's sometimes it's months before the diagnosis is made. In my experience, patients had dysarthria for many months.
Yes.
Only mild swallowing difficulties.
Yes.
And that's the typical way this presents. But once it's diagnosed, it is associated with a worse prognosis.
Yeah. Yeah.
And a diagnosis, you need to be thinking about, insertion of a PEG tube.
Yes. Yeah.
As long as the patient consents to it at an early stage, particularly before they lose respiratory function.
Yeah, that's very important.
Yeah.
So in terms of the etiology, can you enlighten us about this?
Yeah, I mean, MND is largely, we really don't have a good handle on this one, unfortunately. About 10% of cases are genetic, and genes have become much more important in the understanding the etiology of this condition over the last few years. The most common gene associated with this condition is the C9orf72 gene. About 40% of genetic cases of MND have this gene, and there's also a crossover with this gene with frontotemporal dementia.
Right.
And there's other genes. It's probably the second most common gene identified is the superoxide dismutase 1, SOD1 gene mutation. But there are many other genes that have also, with lower incidences being identified with this condition.
Would you routinely test for those, Ernie? Is that part of your clinical workup to maybe
I tend
do those assessments?
not to test a patient for genetic forms of MND unless they have a family history. In which case I'll refer them on to a genetics clinic or to somewhere like an MND Centre of Excellence, like we have in Melbourne at the Calvary Centre, that's Kooyong Road, Caulfield. It runs the MND service for Victoria.
Right.
But there are places in Australia where if you have a new diagnosis of MND and you go to one of these centres, they will automatically test all patients for these genes.
Right.
That's not typical.
And a family history would just be one family member would be enough to make us think about doing this sort of referral.
One family member would be enough.
Yes.
Because then, of course, if they've got one of these common gene mutations, like if, for instance, they've got the C9orf mutation, it's 100% penetrance.
Right. That's a dominant gene, not a recessive gene?
Sorry, these are autosomal dominant genes, I should mention.
Yes.
It's, I guess, a bit like Huntington's disease. If you have one of these conditions and you're an unaffected family member, you may or may want to know whether you're carrying this gene, because it'll be important for you and for future generations.
Yes.
So I actually have a patient who has a C9orf mutation, who's pre-symptomatic. I looked after his father, who in the week I diagnosed MND had been diagnosed with frontotemporal dementia as well.
Right.
And I looked after him until his death about 5 years later. So now his son had genetic testing. He's positive, and I see him every year. And so far, he's in his mid-50s. He has no symptoms. And I guess he's hoping for some sort of genetic treatment in the future, like an antisense oligonucleotide treatment or the like, that may actually influence the natural history of his condition.
Can we say with those inherited types that do they tend to present with the ALS form, or it's not specific to any particular phenotype of motor disease?
The SOD1 type presents with the ALS type.
Right.
But the C9orf, the patient can present either with frontotemporal dementia,
right,
or with motor neuron disease, or with, like the patient I just mentioned, with a combination of those.
Combination of things, yeah. Is there any other, so that's a special case, we might do those genetic testing. Is there any other, like, biomarker? We talked about Parkinson's in a previous discussion and how you would use you would occasionally think about using a dopamine PET scan. Is there anything like that gives us some insights into the diagnosis? Or is it again based more on clinical judgment, your own acumen?
Yeah, look, the diagnosis of MND is basically a clinical diagnosis.
Yeah. Okay.
And it's a clinical diagnosis. We have a high level of suspicion if we see a patient who has, muscle wasting, weakness, fasciculations, particularly fasciculations in various body parts.
Yeah.
And obviously a history of weakness, often a history of cramps, and usually you can be fairly confident making the diagnosis just based on a history and examination. But we'd like to confirm that, and the way we confirm that is to send a patient off for an EMG, and you're looking for evidence of acute and chronic denervation with reinnervation on EMG testing. So usually, putting needles in muscle testing in various parts of the body. And the diagnosis these days has become more refined since a paper was published in 2021 called the Gold Coast Criteria. So a number of MND experts got together on the Gold Coast here in Australia and developed guidelines for a diagnosis of MND, which is mostly based around clinical aspects of the disease and backed up by a well-performed EMG. Right. As well as exclusion of other conditions that sometimes mimic MND, and that's usually by doing neuroimaging. So we often ask for an MRI scan of the brain and spinal cord just to make sure we're not dealing with something else.
Like MS, for example, or whatever, yes.
or some sort of, perhaps, say, for instance, someone has a compressive myelopathy with radiculopathy as well.
So exclusion of other diagnoses is very important. Yeah,
that's right. Yeah.
Can you talk through the etiology in terms of this glutamate excitotoxicity that is talked about and mentioned, and radical-free radicals? Do we know much about all that sort of stuff? Is this something we should know about, or is it?
It's something that I don't know a lot about, because I'm, I guess, mostly a clinician. But there are a number of pathological mechanisms that are thought to be important in the genesis of motor neuron disease. And you're right, glutamate excitotoxicity of neurons, of motor neurons, is thought to be very important. But also many other features, including apoptosis.
Yes.
So what's driving this is the pathology, of course, and we have identified over the past few years that patients with motor neuron disease have intracytoplasmic aggregates of a protein called TDP43 and ubiquitin and the like, and it's estimated that at least 97% of patients have these inclusions in their neurons that lead to cell death, and therefore the clinical manifestations of motor neuron disease, which are mediated by mechanisms like glutamate.
We talked again about Parkinson's, about having maybe environmental factors being relevant. Is there any such discussion in relation to motor neuron disease? Lou Gehrig, sportsman, are we seeing this a bit more in sports people? Is there any relationship between physical activity or whatever and this condition, or is that not really confirmed?
Look, fortunately, it's rare for elite athletes, but you're right. There is an increased incidence on epidemiological studies between elite sports people who do high-intensity exercise and the development of MND. And Lou Gehrig, we know of an AFL footballer in Australia who's also has MND and the like. So it is more likely to occur in that group. It's more likely to occur again with people who've had head trauma. But generally speaking, we're not. The epidemiology hasn't helped a lot when it comes to recognizing MND, and that's probably because there's much more of a genetic component to this condition than perhaps I talked about with Parkinson's.
How do we manage it, Ernie? Once a diagnosis is established, what's our approach to management?
Well, I mean, there are medical things that we can do in terms of pharmacological treatments, which I can talk briefly about.
Yes.
But the major focus of MND, though, is that a patient, I think, with this condition, this horrible condition, should be referred to an MND centre of excellence, because there are clinical studies have shown that a patient will do better. They'll have a better quality of life and a longer life if they're engaged in one of these centres.
Yes.
A multidisciplinary team that involves a neurologist, a respiratory specialist, gastroenterologist for PEG insertion, with all the allied health staff, particularly speech pathology, and also palliative care services when the time is right. In some parts of Australia now, we also have the patients have the option of voluntary assisted dying and legislation being in place.
Yes. Do we, on a pharmacological perspective, what are we considering there? What should we know about?
So the drug we use most in Australia is a drug called riluzole, which is an anti-glutamate agent. So I guess working on that glutamate excitotoxicity you were talking about before, and that's been available in Australia as a sole drug and sole disease-modifying therapy for MND for at least the last 25 years or so. Its side effect profile is low. Occasionally it causes gastrointestinal upset or hepatotoxicity. But in most people it's well tolerated. The FDA have now approved 3 other drugs for the treatment of MND, which are not available in Australia. I don't think these drugs work very well, but there's one called Darivone, which was first developed in Japan. It's been through clinical trials. It has a modest benefit, and it has to be a well-selected patient who goes onto this treatment. It used to just be given intravenously, but there's now an oral form available of this drug. There's a combination, and the next one to talk about is a combination therapy called sodium phenylbutyrate, and I can't pronounce the other drug, torozidol, which is given, and it failed in one drug to achieve any clinical significance in terms of the outcomes. In one trial. In another trial, it was shown to possibly be effective. Again, not available in Australia. And there's an antisense anti-oligonucleotide called tofersen, which is being trialled in SOD1 dismutase genetic MND, which may be effective. And in fact, it's being trialled in a study called the Atlas study, including in centres in Australia, for pre-symptomatic patients who are known to have this genetic mutation, to see if it will help delay the onset of MND. So they're the only drugs available. Look, as a neurologist of long standing, there have been probably 15, 20 other drugs that have been trialled throughout my practicing life. And the majority of MND trials have produced negative results, unfortunately.
Dietary, like the sort of dietary approaches, is there any evidence for any dietary approach? Or
look, there is a suggestion, sorry, not a suggestion, there is certainly good evidence to show that patients who are more obese at diagnosis or who have better nutrition will live longer. So, and most patients with motor neuron disease, because they have swallowing difficulties, will lose weight, will become malnourished.
Yes.
And therefore the disease will progress more rapidly.
Yes.
So it's just a healthy, well-balanced diet, and in fact, trying to put on weight would be useful for this condition.
Yes. Well, it sounds like it's a very difficult condition to manage, and there's a lot of psychological management, support management that sort of comes into play once the diagnosis has been made. And we're fingers crossed that some of these new treatments are going to become available. That glutamate inhibitor that we mentioned at the start, that's been used in Australia for some years, does that prolong life, or is it more just help to control symptoms?
It prolongs life. I mean, there have been Cochrane reviews of this, but the initial clinical trials of this drug show it has a modest efficacy.
Yeah.
It prolongs life maybe by 3 or 4 months.
Okay.
Although the Cochrane review suggested perhaps longer.
Yes.
But in my experience, it doesn't seem to be all that effective.
No.
We don't really have an effective disease-modifying drug for this condition either.
Yes, right. Well, what else should we know about motor neuron disease? Just hopefully that we're going to have some breakthroughs in the future at this stage.
Well, look, apart from the drug treatments, there are many other treatments that we employ to treat the symptoms of Parkinson's. For instance, we talked about peg feeding if needed. The thing that makes the biggest difference to a patient with motor neuron disease life expectancy is non-invasive ventilation.
Right.
And so the majority of patients who die from this condition die from respiratory failure, from type 2 respiratory failure. So it's very important as you follow up these patients to keep an eye on their ventilatory function.
Yeah. Yes.
Once their respiratory function starts to decline, or if they start to develop symptoms such as dyspnea or early morning headache, or extreme tiredness when they wake up in the morning, it probably means that they've been hyperventilating during their sleep. And
there's CO2 retention. Yeah,
that's right, CO2 retention. Time to consider going on to non-invasive ventilation, or BiPAP, as it's called. In Melbourne, for instance, that's usually employed through the Austin Hospital as a service, an outreach service, to allow patients to have better function as a result. And patients initially start using it just at night time when they're lying down, when they're supine, but eventually they need to use it during the daytime as well. And clinical studies have shown that a patient's life can be expanded by as much as a year with this treatment.
Mm.
Now, it's not commonly that we see patients in Australia have tracheostomies for MND.
Yeah.
Most neurologists try and steer their patients away from that, because it's so difficult to employ, and for a patient to be able to go home with that sort of treatment.
Yes.
It's much more commonly, I think, used in the USA than it is in any other country in the world.
Right.
So that's respiration. When it comes to, sometimes people with this condition get hypersalivation or difficulty even swallowing their own secretions. So that can be treated with medications to dry up their saliva, such as, I guess, things like tricyclic antidepressants.
Yes.
You can use atropine.
Yeah, anticholinergics. Yeah.
Yeah, sure. And you can use botulinum toxin injections into the salivary glands, or you can use radiation of the salivary glands, low-dose radiation to, reduce salivary production.
Right.
There are obviously other things we can do for our patients. They have mobility problems and mobility aids. They can contact the Motor Neuron Disease Association of Australia to have subsidised aids. Hospital beds at home. Physiotherapy is important, occupational therapy, regular speech pathology. I recommend my patients see a speech pathologist every 6 months at the minimum. And when it comes to muscle cramps, muscle spasms, you can use drugs like baclofen and the like. So there are many, and as you mentioned, depression, antidepressants.
Yes.
Emotional lability in some patients is a very important symptom that needs to be treated. That's where patients have involuntary, an excessive crying or sometimes laughter.
Yes.
And that can usually be managed with an antidepressant medication.
Yes.
So that they're not inappropriately crying at times that they don't want to be crying. Because not everyone with motor neuron disease becomes depressed. Sometimes these involuntary emotional expressions are present.
Yes. Yeah. There's a lot to the management. And I think what you're highlighting is that even though some of the pharmacological treatments are in development and we're fingers crossed about the future, there are lots of other allied health sort of supports. And you've mentioned things that you can do, like irradiating the salivary glands. I hadn't considered that, but unusual things that we might be a little bit outside the sphere of our normal consideration, but actually can make patients' life a lot more comfortable when they're challenged by such a difficult diagnosis. Ernie, I really appreciate your expertise in taking us through this very sensitive subject of motor neuron disease, a difficult condition to treat. And thank you again for your time and assistance here.
Thank you, Luke. I appreciate it very much.
Thank you. Thank you. I'd like to thank you for joining me with Associate Professor Ernie Butler when we've just discussed motor neuron disease. I found this a very interesting conversation and has certainly improved my awareness, and I hope this has had benefit to your clinical practices. During the podcast series, we will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only and reflect the opinions of the guests interviewed. You can request a new topic which you'd like reviewed and comment about the conversation you've listened to. This is welcomed. Just please send your email responses to manager@gihealth.com.au.